Okay, great. So thank you very much for the invitation to present to this audience today. My name is Keiki Hinami. My title here at Cook County Health is Director of Applied Research in the Center for Health Equity. I'm a physician who just happens to be involved in the several programming that the health system supports around housing insecurity and homelessness. And my role in the program that I'm going to be talking about today, the Flexible Housing Pool program of Chicago and Cook County, I'm the principal evaluator of the program. As such, this presentation is not an introduction to the Flexible Housing Pool program, but really a technical presentation focused on just the data-related feature of this really massive multi-agency collaborative program. I should probably say a little bit more about the Flexible Housing Pool to folks who are possibly not familiar with it. And so it's important, I think, for me to understand who's in the audience. And I hope we could briefly go around to have you state your name, your organization or agency, and I guess whether or not you've heard of the FHP. So starting with folks in Cuneo 417, Teresa.
Yep, sorry, I just had to unmute us. Yeah, so my name is Teresa Newman. I here at Curl, on staff here at Curl at Loyola. And I'm familiar with it only insofar as I've heard my coworkers talk about the project, and I've overseen some of the undergraduate students who are working on it. And I know that you're going to be interviewing folks in maybe a few months from now around some of the services received and how everything's working. So I know that there's some sort of an evaluation happening, and that's what I know.
Great, great. And then the others in the room.
Go ahead.
Hi, my name is Meredith. I am a senior here at Loyola. I'm an undergrad research fellow here at Pearl. And I've heard the program discussed here in the offices, but I don't know, I'm not too familiar with any of the systems. And I'm Ms. Meanshead. I'm a research coordinator here at Pearl. And similar to Teresa, I've only heard our coworkers talk about FHP, not too much of the details. So.
Great.
But
all right, and then I'm just going to go around my screen. Nathan Taylor. I guess each of you may need to unmute yourself. We might need to come back to Nathan. Sarag Prince?
Yeah, Shara. Hi, good morning, everybody. My name is Shara Pinche. I'm at the Information System and Supply Chain Management Department of Quinlan Business School, Quinlan School of Business. And basically, my research interest is in supply chain operations management, sustainable supply chains and sustainable operations management. So I'm looking forward to your talk. It looks like very much of an operations management problem.
Okay, thank you, Sarag. Who's that? Peter Rosenblatt.
Hi, everybody. I'm Peter Rosenblatt. I'm a professor in the sociology department at Loyola, and I study housing and neighborhoods in the US. And so I have not heard very much about the Flexible Housing Pool program, but I'm interested in learning more about it.
Great, thank you.
Thanks.
Damian Nelson.
Hi, everyone. I'm Damian Nelson. I'm the Director of Learning and Impact at the Night Ministry. The Night Ministry is one of the FHP pool sites. So we have several case managers on site who actually administer services to FHP clients. So I know a lot about the program from our client's point of view, but not part of the wider program. So that's what I'm looking to learn more about today.
Great. Hi, now. Mitch Propatiner. Mitch, I'm sorry, you're still muted.
Well, once again, I'm unmute.
We can hear you.
Okay, unmuted now. I'm Mitch Probatiner. I'm a sociologist and independent scholar. I've been a regular at these seminars for some time and have finally gotten around to sitting in on one for this year.
Thank you. Dina Khatib.
Great pronunciation. Thank you. I am Dina El-Khatib, and I work for the Chicago Cook Workforce Partnership, managing our workforce data system, but I have a background in affordable housing and so I was interested in this topic. I don't know anything about the flexible housing pool program, so I'm interested in learning about it.
Great. Welcome, Dina.
Thanks.
Amanda.
Hi, all. My name is Amanda Ward, and I am a research faculty here at Curl. And I am getting increasingly familiar with the Flexible Housing Pool program as we are doing a program evaluation and in the midst of interviewing staff involved with implementing the program.
Great. Thank you, Amanda. Carolyn Pang-Kmet.
Hi, my name is Carolyn Tankamet. I teach in the Information Systems and Supply Chain Management Department over with Cherrig in the Curl School of Business, and I'm here just to learn. Thanks.
Hi, Carolyn. Next is Catherine Doe.
Hi, everyone. My name's Catherine. I'm a dietetic intern over at Loyola. I am not really familiar with the flexible housing pool program. However, it is related to the public health field of nutrition. So I'm definitely interested to learn more about this program.
Great. Hi, Catherine. Samantha Trujillo.
Hi, everyone. I'm Samantha. I'm also a dietetic intern in Loyola's graduate program. I've never heard about the flexible housing program, but I'm excited to learn more about it.
Great. Thank you. Kenneth Satkowski.
Yeah, hi, my name is Kenneth. I am a staff member at the Loyola School of Education. I've not heard about the flexible housing program, but I'm really interested to see how it might affect our teaching students.
Great. Hi, Kenneth. Olivia Farrell.
Hi, good morning, everyone. Olivia Farrell. I am the Director of Policy, Advocacy, and Research for the Network Advocating Against Domestic Violence. As many others have said, I'm not familiar with this, but very intrigued to see how we can work it into some of our research tools and how the housing intersection with domestic violence.
Awesome. Hi, Olivia. Peyton Neufeld.
Hi, I'm a Loyola alum. I've had exposure to Cook County housing policy and evaluation in my recent public policy degree classes, and I'm excited to learn more about the flexible housing program.
Awesome. Welcome, Peyton. Austin Wonder.
Hi, I'm Austin. I'm a graduate student in the sociology department at Loyola, and I recently became a graduate fellow with Curl, working with Christine and Amanda on the flexible housing project.
Awesome. Welcome, Austin. And then Casey.
Hey y'all, I'm also a graduate fellow with Curl. I'm getting my dual MSW JD, and I've been working on the flexible housing pool evaluation since this past January. And prior to that, prior to coming to grad school, I worked in housing in Los Angeles, and I know there's some modeling of this program after some programs in LA. So I'm excited to be on the project.
Awesome. Christine George.
Hi, I am a faculty fellow at Curl and part of the research team for the flexible housing pool process evaluation.
Yep. So thank you, Christine. And then David, of course, introduced himself in the very beginning. He too is part of the research team and probably doesn't need too much of an introduction to this audience assembled today. It's a really diverse group of folks here today, and I really appreciate taking the time out. Did I miss anybody? Okay. If I did, please put your identity in the chat. I guess Nathan is the only person who I thought could introduce himself, but has disappeared. Okay, very good. So let me begin with then just a brief introduction about the flexible housing pool program, since an overwhelming number of you are not too familiar with it. It is a supportive housing program, a permanent supportive housing program that is outside of the coordinated entry system. It is a flexible program in that it is able to define for itself the construct of homelessness. Those of you who may be more familiar with at least the homeless sector, HUD-related funding allocates permanent supportive housing primarily to those experiencing chronic homelessness, and that is technically defined around the duration of homelessness and disability. And it is somewhat a restrictive definition that includes some and excludes others of a very similar phenotype. And so the flexible housing pool, as one of its goals, seeks to broaden the definition of homelessness to allow more folks to be served. The other way that the flexible housing pool is flexible is in our ability to provide a assortment of services in novel ways. So housing tenancy services is the usual support that clients of permanent supportive housing are eligible for, but we are recognizing the involvement of health conditions as being an inseparable experience of a high-risk homeless cohort. And so we are also supporting clients through care coordinators and whatever other health resources that are then referred from a care coordinator to provide the needed health-related supports. It is a health program, meaning it is a marriage between the housing sector and the health sector, motivated by that acknowledgement that illness is inseparable from the experience of homelessness. But because it is a program that seeks to grow, it is motivated by the desire to reduce social expenditures in the care of the clients that we serve. You know, healthcare sector is really driven by cost savings, primarily because it is a very expensive sector, right? It spends a lot of public resources. And so it is motivated by reducing the costs that are consumed by the high-risk homeless individuals that we target for our program. Just like Casey said, we are modeled after a program that was piloted in Los Angeles. Over there, there are more than 3,000 individuals who have been successfully housed through the program. And we are gonna get there as well. The core of this program is a public escrow fund. The city of Chicago is managing an account into which public and private sector agencies could contribute quote unquote investments towards creating new supportive housing units. And so I'll leave the the description of the program, the flexible housing pool program at that. There's a lot more that certainly could be said, and I refer you to the internet for much of the publicly available information out there. Maybe one more thing that I should say as I lead into my disclosure slide, I have no conflicts of interest, but I am supported by the JMP and MCARE Pritzker Family Foundation through the Corporation for Supportive Housing as the principal evaluator of this program. We are a multi-agency partnership. Cook County Health is only one of several agencies that are entangled in this program. The leader of this idea is the city of Chicago. It's their public health department and the Department of Family Support Services, DFSS, that really is the spearheader of this initiative. Corporation of Supportive Housing is the coordinator of the program, and the Center for Housing and Health, the AIDS Foundation, is the principal provider of services around the supportive side of things. But otherwise, we have All Chicago Alliance to End Homelessness in Suburban Cook. We have the Cook County Medical Examiner. We have IDPH. The foundations, and of course, Loyola Curl. And I'm very grateful for all the individuals represented here who I've been lucky enough to recruit as partners for the evaluation of this program. The objectives of the talk today is one, to provide an overview of Cook County Health's strategy for assigning priority to homeless individuals for the flexible housing pool. It's the answer to the question of who do we serve that I want to explain as the meat of our talk today. And to briefly describe our strategy for evaluating utilization costs and other meaningful outcomes for the clients who are served in the flexible housing pool. And then briefly characterize it, the successes that we've had in meeting the program's objectives. So to begin with a really broad high-level background, you know, the current Illinois chief of the strategy to end homelessness in the state, Christine Haley, is prone to say something really interesting. She says, homelessness is about housing. I think she is borrowing from a book, I think, of that same name, but fundamentally, you know, homelessness is a phenomena in the whole spectrum of housing-related problems that none of us here are immune to. And I'm projecting a few figures that I lifted from the 2021 State of Rental Housing in Cook County from the Institution of Housing Studies at DePaul. And the top figure is a comparison bar graph between the supply and demand of affordable rental housing between 2012 and 2019. On the left, darker blue navy bar is the supply, and the sky blue on the right is the demand. And as you can see, every year for the last 10 years, we have seen demand outpace supply, and the gap between that is something like 160,000 households in 2019. And that's the number of individuals who are not able to access the supply of affordable rental housing in Cook County. No wonder, right? Then that those who are vulnerable could end up homeless. In the bottom set of figures, we are displaying the rent burden status. I think maybe some of you may be familiar with this category called housing cost burdened, which means that an individual or a household is spending more than 30% of their pre-tax income on housing, and that's the yellow shade. And what the DePaul group labels extremely burdened is also called severely burdened. That's households spending more than 50% of their pre-tax income on housing. And as you can appreciate, though the group of households who are earning 0 to 30% of the area median income, the majority are severely cost burdened. But even those who are 30 to 50% AMI and 50 to 80% AMI, half or more are already cost burdened. And this really speaks to the absence of resilience to financial crises. These are all households that are experiencing the high risk of losing their housing when the economic downturns that we've experienced leads to a loss or reduction of income. And so these figures are simply intended to support the claim that homelessness is not a isolated phenomena that is only threatening those with serious mental illness or substance use disorder. What they are experiencing, the absence of sheltered places to sleep is something that any one of us in the general population really could experience at the whim of the economic status of our region. I also want to make a claim about how the changes in the cohort of people experiencing homelessness is detectable even through the point in time counts, which is a rather crude way to assess the phenomena of homelessness nationwide. What the point in time count entails is a effort at one point in time, that is usually in January of each year, to count the number of people in emergency shelters and those being served by street outreach services. And in the 2020 report, what they were able to detect is an increase in the number of people experiencing homelessness for the first time, both in the sheltered and unsheltered cohorts. We also saw a rise in the percentage of those who are receiving services for substance use. And then in the next box, you can see that there's also an increase in the proportion of people experiencing physical disabilities, increase especially among the sheltered, those who are formally incarcerated, more men than women, unsurprisingly. And then finally, an increase in the number of individuals not in families with children. That is, these are individual adults. Yeah. So what these these indicators, what they point to is a growing concentration of known risk factors among the group of people that we count among the homeless from year to year recently. This is important to mention because those of us who are looking way back from, let's say, 2009 or 2000, the number of people experiencing homelessness has decreased in the city of Chicago and the county of Cook. But as the decreases have occurred, we are concentrating individuals and households left with certain risk factors. What's happened since the pandemic is a completely different story. What we are seeing is actually a reversal of the gains. We are seeing, again, an increase in the numbers. And so we can't really rest on our laurels for having had a sustained decade of removing individuals from the homeless status into the housed status. One final thing about as background, I want to talk a little bit about numbers. What is the number of people experiencing homelessness in our region. And the point in time counts that I just mentioned, in 2020, we counted 5,220. That's the dark green circle. That number is a large number, of course, but it's not really the final word. Because if we count every distinct individuals recorded in the Homelessness Management Information System, HMIS, which is essentially a registry of those who are in shelter or receiving other services, that number is actually much bigger, 8,160 back in 2017, and probably quite a bit bigger in 2020. And that cohort of individuals registered in HMIS it sits nested in a much larger group of people who are experiencing homelessness in a way that it's difficult to count. The Chicago Coalition for the Homeless releases a number periodically of people who are doubled up or potentially doubled up. And these are people who, when they lost a place to be, when the massive housing projects in Chicago closed down and psychiatric hospitals also closed down, they are currently living in families and friends' homes. They're couch surfing. And that number is 58,723 back in 2019. And I don't want you to think that if they are housed with friends and family, it's somehow a low risk form of homelessness. In fact, in our experience, it's this group who are doubled up that transitions into being unsheltered. They are riding the subways, they are riding the buses, they're under the bridges and encampments. They go back and forth between family and friends being temporarily able to house them to being completely unsheltered. What the health systems encounter is a combination of this group in shelters and those who are avoiding shelters through their experience of homelessness. And what we've been able to do is to join the electronic health record of 6 academic health centers in the region with HMIS to find that only 1/3 of the approximately 3,000 patients who are coded for homelessness, ICD-10 Z59.0, only 1/3 of them have a corresponding record in HMIS, which means that 2/3 of homeless individuals that we see in our emergency departments are potentially at risk of being unsheltered. And it's that group that is usually comorbid with serious mental illness, substance use disorder. They're the ones that are cycling through the various emergency departments in very fragmented ways, also finding themselves cycling through jail. And of course, what this group, I think, will not be surprised to hear is that housing insecurity homelessness is very much a racial equity problem, where in 76% of our region's homeless households are Black African American compared to the 23% of the general population. And so why there's a concentration of African Americans among those who are counted as homeless persisting throughout the year is a concerning signals that we have a systemic way in which race is a disadvantage. And these are all problems that we hope to address through the flexible housing pool. So recognizing that the coordinated entry system, the traditional pathway into permanent supportive housing, doesn't even capture everybody who could be eligible, how do we begin to allocate the new stream of resources that we've created through the program to those who are in need? And I just wanted to project this slide to simply say that it gives us heartburn to think about how to answer this question. It tears us apart. to choose winners and losers. But some of the principles that we have to consider out of necessity includes the following, right? That in the allocation of scarce resources, we consider equality. We want to give everybody a fair chance, and a fair chance can be provided through a lottery system or a random system in which human judgment is not involved in who chooses. The advantages of that is that it is difficult to correct, right? That our judgment can't favor the characteristics that we prefer. So there is a certain fairness to it, but the disadvantages are that it ignores other relevant principles. How about the second one? We could prioritize those who are the worst off, and the housing world does this, right? We use the term vulnerability to justify the prioritization of some over others, and what that vulnerability indicates, it's not that clear, but it is some sort of risk-targeted approach, and it allows us to rescue the most vulnerable by placing those who would otherwise suffer dire consequences of being unhoused, as if others don't suffer adverse consequences for being unsheltered. But then the disadvantages here is that, again, how do we define the dimensions by which we prioritize one over other? And then finally, maximizing the total benefits or utilitarianism. We have to be good stewards of public resources. So we want to provide support services to those who can benefit from them. And these are also important constraints, but all three of these have to be considered in competition with one another, unfortunately. And so these are the conditions the principles that you'll see surface as I describe how we decided to prioritize some over others. I mentioned before that as an investment by the health sector, we want to reduce cost. And this is sort of the utilitarian argument here, right? That we want to demonstrate a cost benefit to the services that we provide. And really, there's an important motivation for this, is because we need other healthcare organizations, including payers, to contribute to the pool. So the more effectively we can show housing can reduce emergency department stays and hospitalizations, we are more likely, we assume, to get the support of hospitals and insurance companies. And it happens to be that Cook County Health is the site of one of the very few randomized controlled trials testing that hypothesis. This was published in JAMA more than 10 years ago at this point, where we randomized folks to a supportive housing intervention compared to the controls who were later than housed. And the conclusion from that study was that there was a detectable difference in hospitalizations, hospital days, and emergency department visits. But more recently, in 2015, a group from Canada conducted a systematic review and a meta-analysis of all of the very few randomized controlled trials to assess the hypothesis about whether or not cost reduction at a societal perspective was in fact achieved. And our study, the Cook County Health study was in there. BA had conducted another RCT, and then the rest were Canadian, right? They had conducted a bunch of very rigorous assessments to measure the consequences of supportive housing interventions. And what the authors of the systematic review concluded is that, in fact, shelter and emergency department utilizations decreased, but whether or not there was an actual overall cost savings was questionable. That is, the point estimate was in the negative directions at times, but there could be an, in fact, net increase in the cost with a housing first intervention. And this shakes up, right? This undermines our whole goal of our program. If this rigorous assessment already has reached the verdict that that randomized controlled trials demonstrates a questionable reductions in cost from a societal perspective, then why? Why, in the face of so much evidence out there that the opposite is true, why is it that we're seeing this outcome from this study? And one of the important things to recognize in our preparatory work in developing the algorithm was the recognition of the regression to the mean phenomena. I don't know if any of you are familiar with the Camden studies in Camden, New Jersey, that is sort of the home to many vulnerable people experiencing homelessness, incarceration, SMI-SUD, the kind of patient that we are also targeting for the flexible housing pool. A randomized controlled trial of their very comprehensive intervention had a null result, and they described regression to the mean as the explanation for why the RCT failed to detect a favorable result. Years ago, actually back in 2015, in Colorado Medicaid, they had really demonstrated this in a very persuasive way. And their analysis is what we replicated in this figure. That is, we took in our health system all the super utilizers, those who were above certain threshold that counts as the highest utilizers of healthcare resources, and we counted them in our index year, January of 2016, and we followed their cohort throughout the subsequent months. And the group that were considered the super utilizers in January extinguished in each subsequent month, meaning they were replaced by other distinct individuals who were then counted among the super utilizers of those months, but the group that were originally identified resolved their crisis or died, right? That the persistent utilization, rather, I'm sorry, that the super utilization is something that is experienced transiently. And so targeting the highest utilizers for interventions like Camden or supportive housing, if you simply measure their utilization in an unmatched cohort study, you'll see that they reduce their utilization. You can claim victory, right? That you can say that whatever it is that you did helped them to reduce their subsequent ED and hospital utilizations. But in fact, it seems as a matter of course, that is, as a natural sequence of events, crises resolve through resolution of their crises or through death. And so simply measuring their outcomes in a cohort study it is going to mislead us. And that's the phenomenon that explains the results of all of the rigorous randomized controlled trials. That is, the control groups also experienced a decrease. And so the effect size of the beneficial societal benefit was much smaller than initially proposed. So what is the mandate from the city? We were asked by the city of Chicago, by we, I mean Cook County Health, me, to one, select a priority population from among individuals that fit the profile of the housing first target population, SMI-SUD, those who are neglected, right? This is the Pete Semberis from New York City, having recognized that a treatment first model tends to find people who are extremely motivated and relatively better resourced to be found in housing, and those who are laden with mental illness, substance use disorder, usually Black men in our cities, are neglected. They are not housed if you prioritize treatment first. But if you house them first, there's some evidence that even they, that is specifically them, who are the most neglected in our society, can also achieve the same outcomes. That is treatment adherence, retention in housing, and then resolution of their chronic comorbidities, for example. we wanted to target that population. Two, we also had to, for attracting investments into the pool, we have to find high utilizers of healthcare and housing services. We were also told that we have to demonstrate cost savings. We were also tasked with creating an algorithm that was portable and flexible. A lot of academic powerhouses can use these black box algorithms, machine learning algorithms, completely opaque about why it will prioritize one or another over another. We couldn't do that, right? We had to have a portable selection algorithm because it wasn't always Cook County Health patients that we were choosing from. That is, investors, if they were payers or other health systems, we would have needed them to also choose from among their patients who would be housed. So the algorithm had to be very transparent and not technically complex. And then finally, the whole evaluation process had to itself be cost effective. And then mandates from also within my own organization, we had to uphold health equity. So in our original cohort, what we did was to match the population that was considered high risk in the Chicago HMIS with Cook County Health and Hospital Systems patient population, as well as members of County Care. County Care is now the largest MCO in the region, and it's a Medicaid program that Cook County Health oversees. And so combining the health system patients who may or may not be insured, that is, health system also is serving a patient population that's 40% uninsured to this day. But we wanted to also include the group that was being supported through our Medicaid managed care program. We found that of the 6,000 patients in the Chicago HMIS cohort, 81% had a corresponding record in Cook County Health. And this really speaks to our catchment, right? We are the public safety net, indeed. The overwhelming majority of people who are in homeless shelters and street outreach use us as their healthcare resource. And we wanted to prioritize from among the approximately 5,000 into the pool. One of the criteria was a high utilization of the city's homeless services. And so we took emergency shelter days, street outreach days, and emergency shelter stays over 2 years, and just selected very crudely the upper 2 quartiles of utilizers from that group. That's pretty crude, but that was what we initially set as our bar. And then from the healthcare side, what we did was avoided cutting a line similarly among the highest utilizers. I think in the Los Angeles program, they initially considered taking the 90th percentile, that is the top 10% of healthcare utilizers, and prioritize them for housing. But because we saw in our prep work, the highest utilizers will experience a regression to the mean and will be experiencing a resolution of crises as a matter of course, whether or not they were housed, effect size of the housing attributable reduction in utilization being obscured, we wanted to choose a different cohort, and we used a much lower bar. And just to sort of illustrate using this figure again, as you can see in the blue, at the very bottom of each bar, you see this is the small number of individual who remain super utilizers through every subsequent month after the first index. And so there are groups of people whose persistent high utilization makes us wonder whether their subsequent reduction in utilization through housing could be detected using a a rigorous comparison. So we chose to use a persistent utilization definition, which was also a fairly low bar. And that bar was at least one emergency department visit or jail registration in Cook County Jail for each of 2 consecutive years prior to the assessment date. And the point system here represents at least one of either ED or jail stay, and then sort of a higher threshold of persistent utilization in the 4-point and the 6-point cutoffs. And what we, at least in the very beginning, were able to find is that if we use this criteria, we find that among the 5,000 or so individuals that meet the cutoff for the housing services criteria, we capture a group that is 96% of whom is using at least one sort of emergency department visit, and a median of 9 emergency department encounters over 2 years, compared to only 2 median encounters in the reference group. Also, jail stays. 28%, more than a quarter of this cohort had at least one jail registration, and the median encounter number over 2 years was 2. Hospitalizations, what we're also finding is that 41%, almost half, are hospitalized, and their length of stay, median length of stay, is 4 days. We also found that in this cohort of healthcare system patients, 55% had SMI diagnosis, 61% with SUD. These are underestimate because folks in jail aren't coded for their condition. So pretty much 55 and 61% to me indicates that really a much larger majority are comorbid with these conditions. In the county care population, that is the Medicaid insured population, we also found a similar phenotype when we applied the 2-point cutoff of persistent utilization. 100% was using ED, 17% using jail, 57% using hospitalizations, and then 3/4 with SMI, SUD, respectively. And with such a low bar for persistent utilization, we needed additional justifications for choosing them. And we used a study published from New York City Medicaid to help justify that. What they did was what's called a sequence analysis, and that clustered Medicaid beneficiaries who are homeless into one of these 6 categories: the high users, the highest users in the bottom right, that's the dark blue, to the second highest users, emerging users, middle users, low users, and very low coverage users, those who are not using healthcare resources. And when they conducted a propensity score matched comparison between a group that was housed in PSH versus those who weren't, they were surprised. We weren't surprised to read this, that the highest utilizers did not experience a housing attributable reduction in healthcare utilization, but almost every other group did. So again, a justification that just simply tapping into the top utilizers may not lead us to detect the utilization that is attributable to housing. On the right side, we repeated the New York City Medicaid group's analyses and I found also a very similar grouping using sequence analysis. And what we ended up doing using our persistent utilizer algorithm is that we strongly weighted against the highest utilizers, and in fact weighted up the likelihood that you'd be prioritized if you were among the lower group, and particularly the second highest group and the emergent utilizer group. And just to provide a case narrative, again, further evidence, right, to justify our decisions about using persistent utilization. These are a couple of synopses. So AE is a 56-year-old man. He had 57 separate emergency department visits over 2 years, 12 inpatient days, 1 shelter stay. So he has a history of asthma, heroin abuse presenting with shortness of breath over several days. He's been taking his albuterol MDI, just the puffer, a few times a day with mild relief. Last had prednisone last week. States that he feels like his own usual exacerbation. Last heroin was used a few hours ago. He inhales it. So this is the right phenotype, right? This is exactly the kind of patient that we wanted to prioritize for housing. Another case example here, AM's a 42-year-old woman, 13 emergency department visits, 43 days in the shelter, 2 shelter stays, HIV, depression, schizophrenia, PTSD, latent syphilis, chronic deep venous thrombosis, untreated due to adherence issues, presents with suicidal ideations. She reported command hallucinations of voices telling her to jump in front of an oncoming train, unable to characterize the hallucination, just too many voices. So again, these are the kind of patients we wanted to prioritize, and our simple algorithm seems to have captured the right group. We're almost done here. I'm gonna shift over to the evaluation strategies, both for the operation of flexible housing pool and evaluation. Because we are using an algorithm based on utilization, we need historical records to help us find the kind of patients that we're looking for. And for that, we need data. And in our strategy, we are joining data from various resources, including Cook County Health, inclusive of county care claims. We're using Cook County Medical Examiner's death record for outcome assessments. We're asking Illinois Department of Public Health to provide their countywide hospital discharge records. So even outside of Cook County Health, even outside of those who are insured, we can capture their emergency department and hospital utilizations through this record. And then the 2 HMIS systems, both from the city, All Chicago, and the Suburban Alliance. Each of these organizations are responsible stewards of their data. We know that there's a lot of confidentiality and privacy restrictions for the release of these data. And so what we are doing is using a technology innovation, PPRL, it's called Privacy Preserving Record Linkage, where we use an algorithm to hash names and dates of birth, the primary identifiers, into one-way codes that is indecipherable gobbledygook that is consistent, though, across the data sources. And we are using a third-party honest broker agency to collect those hashes, join them, and then to create a completely de-identified analytic data set for me to use. And this allows each data contributing agency to avoid releasing PHI, but still participating in the creation of this data set. And so my responsibility for the operation side of the flexible housing pool is to find from among these anonymized individuals those who meet the persistent health utilizer criteria, and then push those hashed codes back to All Chicago and the Suburban Alliance, whom had conducted the consenting process to collect the PHI to be used for the purpose of finding housing, and they'll re-identify them so that they can then be advanced to the Center for Housing and Health and then be looked for, right? That we're not serving the people in front of us. We are finding people in data and then going out to find them. It's a really challenging task, but it is the way that we've decided to go about things. And as a result, over the course of the last few years, since about April of 2019, we've housed about 500 people into the flexible housing pool. And as you can see, this is a histogram of the number of people each month that we have housed. And it's not consistent, right? It's because the first peak here is the Cook County Health original cohort, the inception cohort that we were able to find and house. And as subsequent contributions to the pool have allowed us to create more housing units, we've then recruited additional participants, right, into these housing in boluses. The city of Chicago, as you may recall, when Mayor Lightfoot came into office, she sort of did a little bit of a modification to her original campaign promise to advance our cost and homelessness and really focus just on the youth sector. She contributed $5 million each year over 3 years to end youth homelessness. So the hollow bars that you see here is the number of youths who have been housed into the flexible housing pool more recently. Just really briefly, among the inception cohort from Cook County Health, the group that we've ultimately housed out of 101, 82% men, the plurality 33% 65 or older, 82% Black African American, 39% with a serious mental illness, 55% with a substance use disorder, and a higher prevalence of every other prevalent medical comorbidity than the group that was not prioritized with those who were not successfully housed. So in terms of advancing our health equity objective, I think we have some indicators of success that we are targeting the right population in our program. There's a lot more that we are now beginning to able to present, but and the reason is because we have the aggregated data now, and we're really beginning to scrutinize this data for other important outcome assessments. But these are still being in the process of being vetted by leadership. COVID had a profound impact on challenging some of our assumptions. And so I can't present unvetted analytic outputs today, but at least some of you in the evaluation group will have a chance to scrutinize this in the next few weeks. So the takeaways from what I've presented so far, though, is one, that Cook County Health prioritization scheme for the flexible housing pool replaces high utilization with persistent utilization to better capture the housing first phenotype. And then furthermore, this persistent then high utilizers may be more housing sensitive in their patterns of crisis service utilization and cost. The principal cohort of unaccompanied adults housed through the FHP successfully exhibited the target characteristics. COVID messed things up quite a bit, but sometimes in a good way. More to come. And then finally, the FHP prioritization scheme offers a pathway to identify and capture many more households that may be excluded by HUD criteria, particularly among the justice involved and institutionalized populations.